Good morning. This topic will be all about gallbladder diseases. This topic is divided into three parts. First, we're going to talk about gallbladder stones. Next, gallbladder infections. And then lastly, is gallbladder tumors. Gallstone disease, or cholelithiasis, is one of the most common afflictions of the digestive tract. It is present in between 10 to 15% of adults. Risk factors includes age over 40 years old, multiple women, obesity, use of oral contraceptives and hormonal therapy, diabetic patients, and patients with gastrointestinal diseases. Gallstone is formed when there is decreased bile acid synthesis or increased cholesterol synthesis in the liver, which will lead to supersaturation of bile with cholesterol, and then it will form precipitates, which will then form gallstones. And when there's inflammatory changes, there would be cholecystitis. Gallstones are classified by their cholesterol content as either cholesterol stones or pigment stones. Cholesterol stones are usually yellow-green and made primarily of hardened cholesterol, while pigment stones are small, dark stones made of bilirubin. The exact cause is unknown. They tend to develop in people who have cirrhosis, biliary tract infections, and hereditary blood disorders. Another type of stones are the mixed stones, which is the most common type. These comprise of cholesterol and salts. Clinical manifestations of gallstone disease is most patients will remain asymptomatic from their gallstones throughout life. Others would have postprandial right upper quadrant pain, or what we call the biliary colic. Other diseases of the biliary tree, such as cholelithiasis, cholangitis, gallstone pancreatitis, gallstone ileus, and gallbladder cancer, would also present with biliary colic. These diseases will be discussed in the later part of this topic. Now we go to symptomatic gallstone disease. Symptomatic gallstones typically present with recurrent attacks of pain. The pain develops when a stone obstructs the cystic duct, resulting in a progressive increase of tension in the gallbladder wall as it contracts in response to a meal. The pain is located in the epigastrium or right upper quadrant and frequently radiates to the right upper back or between the scapulae. The diagnosis of symptomatic cholelithiasis or chronic cholecystitis depends on the presence of typical symptoms and the demonstration of stones on diagnostic imaging. An abdominal ultrasound is the standard diagnostic test for gallstones as it is non-invasive and highly sensitive. Gallstones are occasionally identified on abdominal CT scans that were obtained as part of a broader workup of abdominal pain. Surgical cholecystectomy offers the best long-term results for patients with symptomatic gallstones. About 90% of patients with typical biliary symptoms and stones are rendered symptom-free after cholecystectomy. Patients with symptomatic cholelithiasis should be offered elective cholecystectomy. However, if surgery has to be postponed, the patient should be advised to avoid dietary fats and large meals. Diabetic patients with symptomatic gallstones are prone to develop acute cholecystitis. That's why prompt surgery is advised. Pregnant women with symptomatic gallstones, cholecystectomy is feasible and if possible should be done in the second trimester. Now we move on to gallbladder infections. First, we have acute cholecystitis. Acute cholecystitis is an infection of the gallbladder. It is associated with gallstones in 90 to 95% of cases. Obstruction of the cystic duct by a gallstone is the initiating event that leads to gallbladder distension and then to inflammation and then edema of the gallbladder wall. Acute cholecystitis often begins as an attack of biliary colic with relapsing and remitting pain in the right upper quadrant or epigastrium that may radiate to the right back or interscapular area. In contrast to biliary colic, the pain of acute cholecystitis does not subside. It is unremitting, may persist for several days, and is usually more severe than the pain associated with uncomplicated gallstone disease. The patient is often febrile, complains of anorexia, nausea, and vomiting, and may be reluctant to move as the inflammatory process creates focal peritonitis. On physical examination, there would be tenderness and guarding are usually present in the right upper quadrant. A mass, the gallbladder, and adherent omentum is occasionally palpable. However, guarding may prevent infection of these. Murphy's sign is an inspiratory arrest with deep palpation in the right subcostal area. This is characteristic of acute cholecystitis. Laboratory evaluation commonly reveals a mild to moderate leukocytosis. Ultrasonography is considered the most useful initial radiologic test for diagnosing acute cholecystitis with a sensitivity and specificity of 70 to 90%. Ultrasound is effective at documenting the presence of or absence of stones, and it can show gallbladder wall thickening and pericholecystic fluid, both of which are highly suggestive of acute cholecystitis. CT scan can also demonstrate thickening of the gallbladder wall, pericholecystic fluid, and the presence of gallstones, but it is somewhat less sensitive than ultrasonography. Patients who present with acute cholecystitis should receive IV fluids, broad-spectrum antibiotics, and analgesia. The antibiotics should cover gram-negative enteric organisms as well as anaerobes. Although the inflammation in acute cholecystitis may be sterile in some patients, it is difficult to know who is secondarily infected. Therefore, antibiotics have become a standard part of the initial management of acute cholecystitis in most centers. Cholecystectomy is the definitive treatment for acute cholecystitis, and it could either be laparoscopic cholecystectomy or open cholecystectomy. Now we go to gallbladder tumors. Gallbladder cancer, although rare, is the most common biliary tract malignancy and the fifth most common among malignant neoplasms of the digestive tract. It traditionally has been considered an incurable disease with an extremely poor prognosis. The nihilism historically associated with gallbladder stems from its late presentation, often with disseminated disease, overall dismal prognosis, and lack of effective systemic therapy. Gallbladder cancer has a tendency to spread early via lymphatics, hematogenous, and peritoneal metastases, and also has a unique ability to implant along biopsy tracts and wounds. The overall 5-year survival rate, according to reports of gallbladder cancer, is for resectable disease 20% with median survival of just 16 months, and for advanced untreated gallbladder cancer, the median survival is 2 to 5 months. Long-term survival is exceedingly rare. The global incidence of gallbladder cancer varies significantly by geographic region and racial group. It affects women 2 to 4 times more than men. This may be related to the higher rate of cholelithiasis and inflammation in women. The incidence increases progressively with age, both in males and females. It is most commonly diagnosed in the 7th decade of life. The highest incidence of gallbladder cancer is found in Chilean Mapuche Indian women, India, North America. Throughout the world, there is no consistent trends in the incidence of gallbladder cancer, with modest decreases and increases reported in cancer registries from various countries. The most consistently implicated etiologic factor in the development of gallbladder cancer is cholelithiasis. Of gallbladder cancer, 75 to 90% occur in the setting of cholelithiasis. It has been suggested that larger stones have a greater impact on the risk of developing gallbladder cancer. The higher risk of gallbladder cancer development in larger stones possibly reflects the greater duration and intensity of epithelial irritations. Also, we have polypoid lesions of more than 10 millimeters. They are part of the risk. The presence of calcification on the wall of the gallbladder, also known as the porcelain gallbladder, also is a condition associated with higher risk of gallbladder cancer, and also patients with choledochal cyst, sclerosing cholangitis, anomalous pancreaticobiliary duct junction, and exposure to carcinogens such as azotoluene and nitrosamines. There are three common clinical scenarios for gallbladder cancer. Number one, it could be identified by final pathology after routine cholecystectomy. It could be discovered intraoperatively or suspected before surgery. Gallbladder cancer is notorious for being asymptomatic in its early stage. When there is an associated symptom, however, gallbladder cancer tends to present in a similar manner to biliary colic or chronic cholecystitis. In general, The diagnosis of gallbladder cancer should be considered in an elderly patient with constant right upper quadrant pain with weight loss, anorexia, or both. Weight loss, anorexia, and particularly jaundice are signs of advanced diseases. The presence of jaundice is a troubling sign because it suggests porta-hepatis involvement with tumor. Some also would present with ascites. Laboratory findings, if abnormal, are most often consistent with biliary obstruction. Ultrasonography often reveals a thickened, irregular gallbladder wall with hypervascularity or a mass replacing the gallbladder. It may also visualize tumor invasion of the liver, lymphadenopathy, or dilated biliary tree. The sensitivity of ultrasonography in detecting gallbladder cancer ranges from 70 to 100%. A CT scan may also be helpful in identifying a gallbladder mass and evaluating for nodal spread or local invasion into adjacent organs or vasculature. If questions about local invasion remain, MRCP allows for complete assessment of biliary, vascular, nodal, hepatic, and adjacent organ involvement. Endoscopic ultrasound can be a useful tool in staging and evaluating for local invasion, as well as obtaining tissue diagnosis through fine needle aspiration. Tissue diagnosis can also be obtained by CT or ultrasound guided biopsy of the tumor, though this is not required prior to cholecystectomy if the tumor appears resectable on imaging. In jaundice patients, a percutaneous transhepatic or endoscopic cholangiogram may be helpful to delineate the extent of biliary tree involvement. The role of PET scanning in gallbladder cancer is yet to be fully defined but can be utilized in both staging and surveillance. Surgical resection remains the only curative option for gallbladder cancer. While most patients are unresectable at the time of diagnosis, if preoperative staging suggests a potentially resectable tumor, exploration for tissue diagnosis, formal pathologic staging, and possible curative resection are warranted. Re-operation for incidental gallbladder cancer after cholecystectomy is also done. And for patients with beyond stage 1 disease, that is T2 and T3, central liver resection, hilar lymphadenopathy, and evaluation of the cystic stump is done. Radical resection is done for advanced diseases. That would be all for this topic. Thank you for listening and stay safe always.